Welcome. In this session, we'll be discussing about branch retinal vein occlusion. In the previous session, we discussed about central retinal vein occlusion, and as we proceed through this session, we'll be highlighting the differences between branch retinal vein occlusion and central retinal vein occlusion. Branch retinal vein occlusion or BRVO is the second most common retinal vascular disease after diabetic retinopathy, and the meta-analysis suggests a prevalence of BRVO of 0.4% among adults in the general population. In almost all cases of BRVO, the obstruction occurs due to formation of a thrombus in a retinal vein at the site of an arteriovenous crossing, and this is very important to remember. This clinical photograph shows fundus of a patient with a supratemporal branch retinal vein occlusion in the right eye, with the occlusion occurring at this arteriovenous crossing. In contrast to BRVO, where the occlusion occurs at an arteriovenous crossing in the retina, in CRVO, the occlusion occurs in the central retinal vein within the optic nerve behind the lamina cribrosa. At this arteriovenous crossing, the artery crosses anterior to the vein, and both have a common adventitial sheath, and arterial wall thickening and rigidity can lead to compression of the vein at this arteriovenous crossing. Blood flow abnormalities and subsequent trauma to the endothelium due to this compression may result in formation of a thrombus at this location within the vein. Following thrombus formation, there is increased pressure from overload in the tributary veins draining into the site of this occlusion, resulting in intraretinal hemorrhage, macular edema, and macular ischemia. Occasionally, a BRVO starts as a partial occlusion with few intraretinal hemorrhages and mild visual loss, and progresses over time to a more severe degree of occlusion with increasing hemorrhage and further loss of vision. Venous obstruction at a site away from an arteriovenous crossing is uncommon but can occur, and usually indicates an inflammatory etiology such as Behçet's disease, sarcoidosis, and Ehl's disease, and in this group of disorders we will find sheathing of the involved vein. Risk factors of BRVO include age, with prevalence of BRVO increasing with age and peaking between the ages of 60 and 70 years, hypertension, diabetes, smoking, and hypercoagulable and inflammatory disorders, which should particularly be suspected in younger patients and in those without systemic vascular diseases such as diabetes and hypertension. But hypercoagulable disorders are less strongly associated as risk factors of BRVO as compared to CRVO. Ocular risk factors include shorter axial length of the eye and glaucoma. BRVO patients can present with sudden onset painless loss of vision or a visual field defect, but BRVO can also be asymptomatic with occlusion of a branch retinal vein distal or away from the macula, or occlusion of a nasal branch retinal vein. Patients may also present with floaters due to vitreous hemorrhage in an eye which previously had an asymptomatic BRVO. On examination, we find intraretinal hemorrhages and engorgement of retinal veins in a wedge-shaped distribution as seen here in this clinical photograph, with the apex of this wedge-shaped sector pointing towards the site of occlusion in the retinal vein. Distribution of hemorrhage depends on the site of vein occlusion, and severity of hemorrhage as well as that of macular ischemia depends on the degree of occlusion, as seen here in this clinical photograph, where we see dense macular hemorrhage, which implies that the occlusion is more severe. The most common sector involved in BRVO is the supratemporal quadrant, and this is said to be because of more number of arteriovenous crossings in this sector. The blockage site may be identifiable as a narrowed vein proximal to the area of hemorrhage, proximal meaning towards the disc, and other signs which may be present include macular edema, cotton wool spots, and hard exudates. BRVO can be subtyped into two categories, major BRVO and macular BRVO. In major BRVO, one of the four main tributaries of the central retinal vein is affected, as seen here in this photograph, and in macular BRVO, a smaller vein draining a portion of the macula is occluded, as seen here in this photograph. Harry et al. Described the differences between major and macular BRVO and reported that neovascularization occurs almost exclusively in eyes with major BRVO. Macular edema subsides in both major and macular BRVO after a similar duration following onset of BRVO, and following resolution of macular edema in eyes with presenting visual acuity of 20/40 or worse. Visual acuity improved in 69% of eyes with major BRVO and 53% of eyes with macular BRVO. The branch vein occlusion study, or BVOS, classified BRVO as ischemic or non-ischemic, with ischemic BRVO being defined as presence of more than 5 disc diameters of retinal capillary non-perfusion. This is in contrast to the definition of ischemic CRVO by CVOS, which is defined as presence of more than 10 disc areas of retinal capillary non-perfusion. As we have mentioned, hemorrhages are more severe in ischemic BRVO, and also neovascularization develops more commonly in eyes with ischemic BRVO as compared to non-ischemic BRVO. Over time, hemorrhages decrease and disappear, but evidence of prior BRVO may be present in the involved sector as seen here in this photograph, and they include collaterals, non-perfusion, microaneurysms, telangiectatic vessels, and narrowing and sheathing of involved veins, as well as the arteries supplying the involved sector. Collaterals are vein-to-vein channels surrounding the ischemic area, often crossing across the horizontal raphe, which is the horizontal line passing through the foveal center. Collaterals may appear tortuous and resemble neovascularization, but unlike neovascularization, which profusely leak on fluorescent angiography, collaterals do not leak. Epiretinal membrane and retinal pigmentary changes can occur over time, and overall, neovascularization develops in 20% of eyes with BRVO, and neovascularization of the retina is the most common in eyes with BRVO, followed by neovascularization on optic disc, but neovascularization of anterior segment occurs rarely in eyes with BRVO. Neovascularization of the retina in eyes with BRVO typically occurs at the junction of ischemic and non-ischemic areas of the retina, and as we have discussed, neovascularization develops more commonly in eyes with ischemic BRVO as compared to eyes with non-ischemic BRVO. So we may note here that whereas neovascularization occurs most commonly in the anterior segment in eyes with CRVO, neovascularization occurs most commonly on the retina in eyes with BRVO. The vision-threatening complications of BRVO include macular hemorrhage, macular ischemia, macular edema, and neovascularization and its complications, and these are very important to remember. Macular hemorrhage usually disappears with time. Macular ischemia is untreatable, but macular edema and neovascularization can be treated, which we will be discussing subsequently. Rogers et al. Described the natural history of BRVO in a systematic review of more than 1600 eyes and reported that visual acuity generally improved without treatment, but improvement of visual acuity beyond 20/40 was infrequent. They also found that macular edema developed in only 5 to 15% of eyes within 1 year of onset of BRVO, and among these eyes, 18 to 41% of eyes had spontaneous resolution of macular edema within a year. Fluorescent angiography in eyes with BRVO characteristically shows delayed filling of involved retinal vein, but may also show delayed filling of retinal arteries supplying the affected sector of the retina. Hypofluorescence on fluorescent angiography in eyes with BRVO can occur either from retinal hemorrhages causing blocked fluorescence or from non-perfusion of macular and peripheral retinal areas. So in these two photographs, a color photograph and its corresponding fluorescent angiogram, these areas show blocked fluorescence corresponding to hemorrhage in the color photograph, and these areas show capillary non-perfusion, which do not have any corresponding blocking material in the color photograph. Retinal hemorrhages make assessment of other signs on fluorescent angiogram impossible, and so fluorescent angiography should ideally be done after adequate resolution of hemorrhage. On the other hand, hyperfluorescence can occur from macular edema as shown here in this angiogram, or from neovascularization, which show profuse leakage of fluorescein. In this fluorescent angiogram, we find both areas of fluorescent leakage indicating macular edema and areas of capillary non-perfusion. This area of retinal capillary non-perfusion extends from the normal foveal avascular zone and makes the margin of the foveal avascular zone irregular. Following resolution of hemorrhage, sectoral distribution of vascular abnormalities as seen here in this fluorescent angiogram can indicate the sector affected in the prior episode of BRVO, and these vascular abnormalities include non-perfusion, microaneurysms, and collaterals which may cross the horizontal raphe. In eyes with BRVO, OCT may show macular edema as retinal thickening, intraretinal fluid often as cystoid macular edema, and subretinal fluid as seen here in this OCT. And in a vertical OCT scan in an eye with BRVO, typically the corresponding side of the foveal center, either superior or inferior, is affected more severely. Retinal thickness maps can indicate the involved area of the retina, and one advantage of OCT over fluorescent angiography is that in the acute stage of retinal venous occlusion, OCT can detect macular edema even in the presence of significant macular hemorrhage, thus documenting the presence of macular edema early and enabling early initiation of anti-VEGF or steroid therapy, which has been found to be beneficial in the management of BRVO. Also, macular thickening on OCT in the absence of macular leakage on fluorescent angiography is said to be due to macular ischemia itself. Intraretinal hemorrhages and hard exudates appear as intraretinal hyperreflectivity on OCT with posterior shadowing as seen here in this OCT. And disruption of ellipsoid zone on OCT signifies photoreceptor dysfunction and predicts a poor visual outcome. OCTA can detect capillary non-perfusion as well as dilated collateral vessels. In this photograph, these are magnified views of fluorescent angiograms with their corresponding OCTA images. These two images show a collateral vessel, and this OCTA image shows an area of capillary non-perfusion with areas of dilated capillaries which show limited leakage on fluorescent angiogram. Both capillary non-perfusion and dilated collateral vessels are more prominent in the deep retinal capillary plexus on OCTA, and this is said to be because the major venous outflow of retina is from the deep retinal capillary plexus. Other features which may be found on OCTA include microaneurysms, ghost vessels, and neovascularization. And in the acute phase of retinal venous occlusion, there can be artifacts on OCTA due to edema, hemorrhage, and suspended particles in motion, which may occur within cystoid spaces. And it has been shown that perfusion of deep retinal capillary plexus on OCTA correlates with final visual acuity. Systemic workup of patients with BRVO include blood glucose, blood pressure, and lipid profile evaluation to detect undiagnosed systemic vascular diseases, and in patients without systemic vascular diseases, workup for hypercoagulable and hyperviscosity disorders are indicated, particularly in younger patients, in patients with bilateral or multiple episodes of BRVO, and in those with personal or family history suggestive of hypercoagulable and hyperviscosity disorders. Differential diagnosis of BRVO include hypertensive retinopathy, diabetic retinopathy, and radiation retinopathy, particularly when the retinal vascular lesions in these disorders are localized to a sector of the retina, and macular telangiectasia as well as retinal angiomatous proliferation. Systemic management of BRVO includes treatment for associated diabetes, hypertension, and hyperlipidemia, and in patients with these systemic vascular diseases, anticoagulation has not been found to be beneficial and may actually increase the severity of hemorrhage. And if hypercoagulable, hyperviscosity, and inflammatory disorders are detected, they must be treated. The BVOS group evaluated the role of sectoral retinal photocoagulation for neovascularization and also the role of grid laser photocoagulation for macular edema in eyes with BRVO. For evaluating the role of sectoral retinal photocoagulation in eyes with BRVO, BVOS included two cohorts of patients, one with ischemic BRVO but without neovascularization, and the other with ischemic BRVO and neovascularization. In the cohort of patients with ischemic BRVO without neovascularization, BVOS randomized 319 eyes either to sectoral retinal photocoagulation or to observation for a mean follow-up period of almost 4 years. And in this cohort of eyes with ischemic BRVO but without neovascularization at baseline, 20% of treated eyes developed neovascularization, whereas 40% of observed eyes developed neovascularization, and the difference between these two were significant. And in the other cohort of eyes with ischemic BRVO and neovascularization, BVOS randomized 82 eyes either to sectoral retinal photocoagulation or to observation for a mean follow-up period of almost 3 years. And in this cohort of patients with ischemic BRVO with neovascularization at baseline, BVOS found that 30% of treated eyes developed vitreous hemorrhage, whereas 60% of eyes being observed developed vitreous hemorrhage, and the difference between these two groups was significant. And the BVOS recommended that sectoral retinal photocoagulation should be done only if neovascularization is present or develops during follow-up, provided adequate follow-up can be maintained. This is because without treatment, only 40% of eyes with ischemic BRVO develop neovascularization, and treatment itself results in further visual field loss in the affected sector. And this recommendation of BVOS for BRVO is similar to the recommendation of CVOS for CRVO. For sectoral retinal photocoagulation, as seen here in this clinical photograph, 500 micron mild white intensity burns are placed one burn width apart, and these burns are placed in the area of non-perfusion detected on fluorescent angiography, but sparing the region within 2 disc diameters from the center of the fovea. So for performing adequate sectoral retinal photocoagulation, fluorescent angiography is mandatory, and areas of significant intraretinal hemorrhage should be avoided during sectoral retinal photocoagulation. The BVOS also evaluated the role of grid laser photocoagulation for macular edema, and for this BVOS randomized 139 eyes with non-ischemic BRVO with visual acuity worse than 20/40 due to macular edema as evidenced by fluorescent angiography to either grid laser or to observation. So we note here that like CVOS, BVOS also was a pre-OCT and pre-anti-VEGF era study. In the grid laser group, grid laser was done in areas of leakage detected on fluorescent angiography but sparing the foveal avascular zone, and patients were followed up for a mean of more than 3 years. And BVOS concluded that grid laser photocoagulation is recommended in eyes with BRVO without foveal hemorrhage or ischemia and having visual acuity of 20/40 or worse due to macular edema. And it is very important to note here that this is in contrast to CVOS, which did not recommend grid laser photocoagulation in eyes with macular edema from CRVO. This table shows the 3-year data from BVOS, with grid laser group showing superior visual acuity improvements as compared to observation group. For administering grid laser, sufficient time, almost 3 to 6 months, should be given for macular edema to resolve spontaneously, for foveal and macular hemorrhage to clear, and to obtain a good quality fluorescent angiogram. And it is important to note that in contrast to grid laser, these requirements need not be satisfied prior to injection of anti-VEGF drugs. Grid laser is applied to areas of macular leakage on fluorescent angiography, avoiding the foveal avascular zone. This photograph shows a fluorescent angiogram with the shades reversed, with this area showing hyperfluorescence due to macular leakage, and this hyperfluorescent area corresponding to the foveal avascular zone. And this is the color photograph of the same eye following application of grid laser to the area of macular leakage. So a fluorescent angiogram is mandatory prior to application of grid laser. The grid laser burns are of mild green intensity, at least 500 micron from the center of the fovea, with 500 microns being the approximate diameter of the foveal avascular zone. The leaking vessels are not directly treated during grid laser. Also, areas of capillary non-perfusion on the corresponding fluorescent angiogram are not treated. Currently, grid laser photocoagulation is reserved for patients who do not respond adequately to anti-VEGF and/or steroid injections. But the DILATE and BRIGHTER trials did not show any additional benefit of scattered grid laser in BRVO patients being treated with ranibizumab. Intravitreal steroids are used to treat macular edema in eyes with BRVO, and intravitreal steroids are said to act by stabilizing blood-retina barrier and reducing production of cytokines, including production of vascular endothelial growth factor. Intravitreal steroids have well-known side effects of raised intraocular pressure and cataract progression, and currently intravitreal steroids are reserved for patients who do not respond adequately to to anti-VEGF and/or grid laser, and intravitreal steroids are particularly preferred in pseudophakic eyes who have been shown not to be a steroid responder. So currently, anti-VEGFs are considered first-line agents in the treatment of macular edema from BRVO, and either intravitreal steroids or grid laser can be administered in eyes not responding adequately to anti-VEGF. The SCORE-BRVO trial compared the safety and efficacy of two doses, namely 1 mg and 4 mg of triamcinolone and grid laser for the treatment of macular edema in eyes with perfused BRVO with visual acuity between 2040 and 2400. Triamcinolone injections and grid laser were administered at baseline and could be repeated every 4 months in the absence of significant improvement or in the absence of significant adverse effects. A total of 411 patients were randomized to these three groups, one receiving 1 mg triamcinolone, the second receiving 4 mg triamcinolone, and the third receiving grid laser. So, whereas in the SCORE trial for CRVO, these two doses of triamcinolone were compared with observation because grid laser was already established to be not effective for macular edema in CRVO. The SCORE-BRVO compared these two doses of triamcinolone with grid laser, which has already been established to be effective in macular edema for BRVO. The SCORE-BRVO study concluded that both 1 mg and 4 mg triamcinolone was equivalent to grid laser, but the incidence of adverse effects such as cataract and elevated intraocular pressure were much higher in the 4 mg triamcinolone group as compared to the grid laser group. So in view of possible adverse effects from triamcinolone injections, the SCORE-BRVO study recommended grid laser photocoagulation for macular edema secondary to BRVO. This table shows the 12-month and 36-month results from the SCORE-BRVO trial. The GENEVA study, which we have discussed in the previous session on CRVO, compared the safety and efficacy of single administration of two doses of intravitreal dexamethasone implant 0.7 mg and 0.35 mg versus sham in eyes with retinal venous occlusion, both central and branch retinal venous occlusion, and with vision loss due to macular edema. And among eyes with BRVO in the GENEVA trial, there was a significant difference in visual acuity gains between the dexamethasone groups and the sham group till 90 days after the injection. At the end of 6 months, all patients received repeat treatment with dexamethasone 0.7 mg, and at 12 months the study found that in the initial dexamethasone groups, visual acuity results were similar to that achieved at month 6, and in the initial sham group, although the visual acuity improved in the second 6 months, the gains were not similar to the groups receiving dexamethasone implant at the beginning of the study. Also, in the initial dexamethasone group, although the incidence of elevated intraocular pressure remained the same at 12 months as at the end of 6 months following the first injection, the incidence of cataract increased in the second 6 months as compared to the first 6 months following the second injection at 6 months. Anti-VEGFs have become the first-line therapy for macular edema following BRVO because, as we have discussed multiple times, VEGF secreted by ischemic retina is the major molecule which has been implicated in macular edema as well as neovascularization. Intravitreal ranibizumab, aflibercept, and faricimab have been approved for use in BRVO-induced macular edema. Anti-VEGF should be administered as early as possible following diagnosis of macular edema secondary to BRVO, and this is very important to remember. Brolucizumab has not been approved for this indication, and bevacizumab is not FDA approved for intraocular use but is widely used because of its much lower cost per patient. BRVO was a phase 3 trial to evaluate the safety and efficacy of two doses of ranibizumab 0.3 mg and 0.5 mg versus sham in macular edema due to BRVO and with visual acuity between 2040 and 2400. A total of 397 patients were included in this study and were randomized to 3 groups, one receiving monthly injection of 0.3 mg ranibizumab, the second receiving monthly injections of 0.5 mg ranibizumab, and the third receiving sham injections monthly. And patients in any of these groups could receive rescue grid laser at or after 3 months, but only once in the first 6 months if they met pre-specified criteria. At 6 months, the study concluded that 0.3 mg and 0.5 mg ranibizumab provided rapid improvement of visual acuity and reduction of macular edema with low rates of ocular and non-ocular adverse effects. So this table shows the 6-month results from the BRVO trial. After 6 months, patients in any of the 3 groups with BCVA 20/40 or worse and central subfoveal thickness 250 micron or more received monthly ranibizumab injections, and grid laser was administered if pre-specified criteria were met, but only once during the second 6 months. Pre-specified criteria meaning criteria usually based on visual acuity and retinal thickening on OCT, based on which retreatment was decided, and we'll be coming across this term several times. At the end of 12 months, the BRVO study concluded that patients in the ranibizumab groups in the first 6 months on average retained their visual acuity and anatomic gains, which were achieved at the end of the first 6 months. And patients in the sham group in the first 6 months treated with ranibizumab as required in the next 6 months had rapid reduction in central foveal thickness similar to the groups which received ranibizumab in the first 6 months, and also had gain in visual acuity but not to the same extent as the groups which received ranibizumab in the first 6 months, showing that early initiation of treatment for BRVO induced macular edema is imperative. This table shows the 12-month results from the BRVO trial. The Horizon was a 12-month extension trial of patients in the CRUISE study for CRVO-induced macular edema and the BRVO study for BRVO-induced macular edema. In this study, patients were followed up every 3 months and given 0.5 mg ranibizumab if they met pre-specified criteria. At the end of 24 months from the baseline of the CRUISE and the BRVO study, the Horizon study concluded that patients from the CRUISE study had decline of visual acuity, while patients from the BRVO study remained stable since the end of the CRUISE and the BRVO trial, and the proportion of patients from the CRUISE study who had a gain of 15 or more letters from baseline declined as compared to the proportion at the end of 12 months, but this was not so in the BRVO study. The Horizon study thus concluded that CRVO eyes required closer follow-up. This table shows the results of the Horizon study. The Retina was a further 2-year extension trial of patients who completed Horizon trial, and this study had 32 CRVO eyes and 34 BRVO eyes. Patients were examined monthly in the first year of this trial, that is in the 3rd year since the baseline of the CRUISE and the BRVO trials, and at least every 3 months in the next year. An intravitreal 0.5 mg ranibizumab was administered according to pre-specified criteria. So in the Retina study, closer follow-up and more frequent injections could be administered as compared to the previous Horizon study. And at 49 months from baseline, the Retina study concluded that long-term outcomes in the BRVO group were excellent, and a substantial proportion of patients in the CRVO group had good visual outcome. And these were the data in the Retina study. The SHORE study compared the efficacy of monthly ranibizumab versus PRN ranibizumab in patients with macular edema due to retinal vein occlusion, either BRVO or CRVO. In this study, all patients received initial 7 doses of monthly 0.5 mg ranibizumab, following which patients whose macular edema stabilized after the initial 7 doses were randomized to receive either monthly ranibizumab 0.5 mg or to monthly follow-up and PRN injections till 14 months, and the remaining patients whose macular edema did not stabilize after the initial 7 doses of monthly ranibizumab continued to receive monthly ranibizumab. At 15 months, the SHORE study concluded that following resolution of macular edema, there was no significant difference between monthly and PRN ranibizumab injections in maintaining visual acuity gains and controlling macular edema. This table shows the 15-month results from the SHORE trial. The CRAVE study compared the efficacy of 1.25 mg bevacizumab versus 0.5 mg ranibizumab, each administered in a monthly regimen in patients with macular edema due to BRVO and having a visual acuity between 20/40 and 23/20. And at 6 months, this study concluded that monthly bevacizumab and monthly ranibizumab injections have similar effects in improving visual acuity and reducing macular edema in eyes with macular edema secondary to BRVO. And this table shows the 6-month data from the CRAVE trial. The MARVEL trial compared the efficacy of 1.25 mg bevacizumab versus 0.5 mg ranibizumab each administered in a PRN regimen in patients with macular edema due to BRVO and having a visual acuity between 20/40 and 23/20. And this trial randomized 75 patients into two groups, one receiving bevacizumab and the other receiving ranibizumab. In both the study groups, injections were given at baseline and the patients were followed up monthly in the first 6 months and every 2 months in the next 6 months. PRN injections were given at follow-up visits based on pre-specified criteria. Grid laser was performed as required in the second 6 months, and grid laser could be repeated at an interval of 3 months or more. The MARVEL study concluded that visual acuity gains in the bevacizumab group were non-inferior to the visual acuity gains in the ranibizumab group, and reduction in central retinal thickness was also not significantly different between the two groups, but more patients in the bevacizumab group required grid laser. And this table shows the data from the MARVEL trial. The COMRADE-B trial compared the efficacy of 0.5 mg ranibizumab versus 0.7 mg dexamethasone implant in macular edema due to BRVO. 244 patients were randomized to receive either ranibizumab monthly for 3 doses followed by PRN injections or a single administration of dexamethasone. At 6 months, the COMRADE-B study reported that visual acuity results were similar in the two groups at the end of 1 and 3 months, but ranibizumab group had better outcomes following the initial 3 months, and ocular adverse effects were more common in the dexamethasone group. After 6 months, patients were followed up monthly and received treatment as required. And at the end of 12 months, the COMRADE-B study reported that although there was no significant difference between the visual acuity results of the two groups, the results were better in the ranibizumab group. Vibrant was a phase 3 trial comparing the efficacy of intravitreal aflibercept versus grid laser in the treatment of macular edema secondary to BRVO of less than 1 year's duration with visual acuity between 20/40 and 23/20. A total of 183 patients were included and were randomized into two groups, with one group receiving 5 doses of aflibercept 2 mg every 4 weeks and the other group receiving grid laser at baseline. And each of these two groups could receive grid laser after 12 weeks since baseline if pre-specified criteria were met. At 24 weeks, the study concluded that aflibercept gives significantly better visual acuity gains and reduction in CST in macular edema secondary to BRVO. This table shows the data at 24 weeks in the Vibrant trial. From week 24 onwards, patients in the original aflibercept group received aflibercept 2 mg injection every 8 weeks, and in this group grid laser could be administered if required at week 36, that is another 12 weeks following the initial 24 weeks. And patients in the initial grid laser group, if pre-specified criteria were met, received aflibercept 2 mg every 4 weeks for 3 doses followed by aflibercept every 8 weeks. And at 52 weeks, the study concluded that in the initial aflibercept group, aflibercept injections administered every 8 weeks maintained visual gains and control of macular edema, and in the initial laser group, rescue aflibercept injections resulted in substantial visual acuity improvement. This table shows the data at 52 weeks in the Vibrant trial. The BALATON trial compared the safety and efficacy of intravitreal faricimab versus aflibercept for treatment of center involving macular edema from BRVO. 553 patients were included and were randomized to receive either faricimab 6 mg or aflibercept 2 mg every 4 weeks for 24 weeks. At 24 weeks, the BALATON study concluded that BCVA gains with faricimab were non-inferior to BCVA gains with aflibercept, and also reduction in central subfield thickness on OCT achieved with faricimab and aflibercept were comparable, but greater proportion of patients receiving faricimab achieved absence of fluorescent leakage as compared to patients receiving aflibercept. This table shows the 6 months data from the BALATON trial. Vitrectomy with schizotomy has been attempted in eyes with BRVO and is aimed at incising the adventitial sheath at the arteriovenous crossing. This procedure has been shown to reduce macular edema as well as intraretinal hemorrhages, but is not used in routine clinical practice because of risk of significant complications. Vitrectomy with posterior hyaloid separation with or without schizotomy can also reduce macular edema, but without significant difference in visual acuity gains, and so is not routinely used. Indications for vitrectomy in eyes with BRVO include significant non-clearing vitreous hemorrhage interfering with vision for several months, and in this situation vitrectomy allows sectoral laser in the non-perfused sector of the retina with the help of the endolaser and tractional retinal detachment involving the macula. And the follow-up protocol for patients with BRVO is as follows. Initially, when the risk of macular edema and neovascularization is high, the patient should be followed up every month. When macular edema resolves or stabilizes, follow-up intervals can be extended to 3 to 6 months and then even longer. Eyes with ischemic BRVO which has not received treatment due to absence of neovascularization should be followed up every 3 months long term after the initial 6 months. To recap the salient points, branch retinal vein occlusion or BRVO usually occurs due to formation of a thrombus in a retinal vein at the site of an arteriovenous crossing. Risk factors include age, hypertension, hyperglycemia, short axial length, glaucoma, hypercoagulable and inflammatory disorders. BRVO usually presents with sudden onset of visual loss or visual field defect. It can also be asymptomatic if the affected area is peripheral to the macula. Visual loss results from macular hemorrhage, macular ischemia, macular edema, and complications of neovascularization. On examination, intraretinal hemorrhages and dilated retinal veins are found in a sectoral distribution which is often west-shaped, with the apex of this west-shaped area directed towards the arteriovenous crossing where the occlusion occurred. Cotton wool spots and hard exudates may also be seen in the affected area. Over time, hemorrhage decreases, collaterals can be detected which often cross the horizontal raphe, and neovascularization may develop, most commonly on the retina and very rarely on the iris. The branch vein occlusion study or BVOS classified BRVO into ischemic and non-ischemic types. Ischemic BRVO is characterized by the presence of 5 or more disc diameters of retinal non-perfusion on fluorescein angiography. Hemorrhages are more severe and risk of neovascularization is higher in ischemic BRVO. Fluorescein angiography may show delayed filling of affected retinal veins, hypofluorescence from hemorrhages or ischemia, and hyperfluorescence from macular edema and neovascularization. Fluorescein angiography should ideally be done after hemorrhages decrease sufficiently. Following disappearance of hemorrhage, sectoral distribution of capillary non-perfusion, collaterals, and microaneurysms on FA can point towards a prior episode of BRVO. OCT can detect macular edema even in the presence of macular hemorrhage. It can also show disruption of ellipsoid zone, which portends poor visual prognosis. OCTA can detect non-perfused areas, collaterals, and neovascular networks. Systemic workup for hypercoagulable disorders are indicated in patients without systemic vascular disease, particularly in those who are young, have bilateral or multiple episodes of BRVO, and those with a personal or family history suggestive of hypercoagulable disorders. Differential diagnosis of BRVO include hypertensive retinopathy, diabetic retinopathy, radiation retinopathy, macular telangiectasia, and retinal angiomatous proliferation. Management includes systemic measures and ocular treatment. Systemic measures include control of systemic vascular diseases such as diabetes and hypertension, and treatment of hypercoagulable and inflammatory disorders if detected. Ocular treatment is directed towards macular edema and neovascularization. BVOS, a pre-anti-VEGF era study, recommended grid laser to areas of leakage on fluorescein angiography for macular edema, and also recommended sectoral retinal photocoagulation to areas of retinal capillary non-perfusion on fluorescein angiography only if neovascularization develops. SCORE-BRVO trial found that intravitreal triamcinolone and grid laser were equally efficacious in the treatment of macular edema due to BRVO, although triamcinolone was associated with increased incidence of side effects. The GENEVA study showed that intravitreal dexamethasone implant is also effective in improving vision in eyes with macular edema due to BRVO, particularly if initiated early following diagnosis. BRVO trial showed that intravitreal ranibizumab was effective in improving visual acuity in eyes with macular edema due to BRVO, particularly if initiated early following diagnosis. The Horizon and Retina extension trial showed that long-term results were better in eyes with BRVO as compared to eyes with CRVO. The Vibrant trial showed that aflibercept was superior to grid laser, and the BALATON trial showed that faricimab was non-inferior to aflibercept in the treatment of macular edema due to BRVO. Vitrectomy is indicated for complications of neovascularization such as non-clearing vitreous hemorrhage and tractional retinal detachment. Patients with BRVO should be initially followed up monthly, and following resolution or stabilization of macular edema, patients with non-ischemic BRVO can be followed up at longer intervals, but patients with ischemic BRVO should be followed up closely long term. Thank you for listening.